Welcome to OrthoNeuro's Orthopedics for the Primary Care Physician, Q1 of 2022. Tonight's speakers will be Drs. Nicholas Cheney, orthopedic foot and ankle surgeon, Dr. Mark Gittins, hip and knee surgeon, Dr. Ben Szerlip, shoulder and elbow surgeon, and Dr. James Cassandra, hand and elbow surgeon. We will have a short Q&A period following each speaker's presentation. Please type your Q&A questions in the Q&A box at the bottom of your screen. You will be emailed a program evaluation and a participant assessment following the seminar, which needs to be completed and returned for you to receive CME credit. This course has been approved for 2 Category 1A credits from the AOA. I will submit those credits to the AOA for each participant. Our first speaker of the evening is Dr. Nicholas Cheney. Dr. Cheney?
All right. All right, can everybody see the screen? Heather, are we good? Can you see it, Heather? Good. Okay, perfect. Yes, thanks. Good. All right, so normally I give my gastric equinus talk, but I wanted to talk about common foot and ankle injuries, or specifically ankle injuries that I see primary care docs send over a lot, which we're grateful for, but something that might make your lives easier to kind of know what to do with some of these folks. So my disclosures are irrelevant this evening, but there they are. Objectives, talk about ankle sprains. I mean, that's an exceedingly common problem. See it all the time. High ankle sprains, that's always the concern is it an ankle sprain or a high ankle sprain? Obviously the treatment between the two is different. We'll go into a little bit of the anatomy and just some of the basics with that stuff, and then kind of how to manage it. And then Achilles ruptures, that's another one that I see commonly, that, some of the treatment for Achilles ruptures has evolved and changed, and for the better. And we'll kind of go into that as well. So first and foremost, ankle sprains, very common. It's an inversion injury. So that's of utmost importance. When I'm taking a history on a patient sent in with an ankle injury, I want to know, did they invert it? Did they evert it? What was the mechanism? It's fairly common, 2.15 patients in 1,000 in the US. Obviously, 10 to 19-year-old age group has a little higher incidence, and those are the kids that are doing the middle school, high school sports. There's a higher rate in males, probably a little bit more aggressive. Females over 30, I would assume that probably has something to do with shoe wear, heels, wedges, those types of things, and more than half occur during sports activity. And that was out of a JBGS study in 2010. And so just a little review of the anatomy. Everybody remembers this. I remember first aid, studying for step 1 boards, ATFL always tears first. So a very, very common ligament injured, but I think one that gets not enough attention is the CFL ligament. So that CFL ligament, if you look, attaches in the base of the fibula and then attaches to the calcaneus down here. So it doesn't actually attach to the talus. So that stabilizes both the tibio-talar joint, the ankle joint, as well as the subtalar joint. And that for me is kind of the biggest challenge with these inversion injuries. And then you've got your posterior talofibular ligament. So that's one that we really don't discuss, we don't approach, we don't address. It's the ATFL and the CFL are your big culprits. What else can you see with these ankle sprains? We get a lot of folks sent over with ankle fractures, and they've got these little, avulsion type injuries and the little avulsion injury off the dorsal navicular, off the dorsal talus. And so if you think about it, every joint has the capsule that holds that synovial fluid in. And so when you invert these ankles or you twist on them, you can get little avulsions. So here's your lateral ankle ligament, it's probably your CFL ligament primarily from that inversion injury. Is kind of, instead of necessarily tearing, disrupting those ligaments, it's actually avulsed a little piece of bone here. And so we'll kind of go into the importance of that, but those are common findings. They're more indicative of a severe ankle sprain with capsular involvement. So don't freak out if you see that. Pretty common thing. And it doesn't change the stability of the joint at all. With a fracture, we're more concerned about the stability of the joint. So depending on where the fracture is on the ankle, we worry about the stability, but this is more with an inversion injury. These are still considered stable injuries, so surgery is not indicated. So grade of sprains 1, 2, and 3. Again, type 1 is a strain, 2 partial tear, 3 is a full tear. Really, there's no way of knowing what that is when you look at the patient. An MRI is not going to really be able to tell you that, and it's not really all that relevant. As I like to tell my patients, ACL tears, those get surgery right away. The problem is that ACL lives within the knee joint. It does not have a blood supply and so it doesn't heal on its own. These ligaments live outside of the joint capsule, and so they do have a blood supply, so they will heal. So that's why surgery is not indicated for acute ankle sprains. Presentation, a lot of times it happens so fast, patients don't recall. But if at all possible, if you can get, did your foot turn in, did it turn out? You want to make sure it's not an eversion type injury where these more significant problems develop. Inversion injuries will be a classic sprain almost universally. Presentation, so patients will have pain over the ATFL, CFL here, kind of that classic anterior lateral ankle joint. You can have pain over the peroneal tendons. They can have pain medially over the deltoid ligament, over the inside of the ankle joint where that bone basically kind of impacted and caused some problems. And really, how do I tell what grade of injury the patient had? Really, the more significant the swelling, the more black and blue, the more painful, probably the more severe the injury. The only difference with that would be if somebody has some chronic instability. So they've got the rubber band that's all stretched out and they roll the ankle, they may have had a 90-degree inversion injury to that ankle. But if they've got a pre-existing loose ankle, you may not see that same kind of swelling and ecchymosis that you would normally see with a standard acute sprain. So that's something to keep in mind as well. How do you diagnose this stuff? Obviously inversion injury, you want to make sure they have pain in those locations. It's pretty classic. Any pain over the bone, fibula, median malleolus would be more concerning for a ankle fracture. And so you want to make sure there was no external rotation mechanism there. Range of motion limited to pain pretty much always. You're not going to really be able to get these people to move a whole lot. So really what the history, where their pain, what the mechanism was and where their pain is really going to be your biggest guide. And typically these x-rays are negative for fractures, other than some of those avulsions that we talked about. The other avulsion that I didn't mention was like the anterior lateral process of the calcaneus. We'll see a lot of avulsion injuries there as well. And again, it's depending on the size of that fracture and the displacement, most of the time that's a non-surgical problem. Management, so it depends on the severity. So obviously I get a grade 2 to 3 sprain. I'm going to immobilize them in a boot, some range of motion to try to decrease swelling, maintain motion, and then standard RICE treatment, and then therapy once things have calmed down. Somebody with a less aggressive sprain, grade 1, 2, we could potentially put them in something less restrictive than a boot, like an ASO or a Sweeto brace, kind of like what you see there. The important thing to keep in mind with these is, it allows ankle dorsiflexion and plantar flexion, but it's got these plastic stays or metal stays on the sides that provides that side-to-side support that the ankle needs. And so sometimes I'll get patients in therapy right away with this. So why is treating this important? Again, if we don't treat this the right way, those ligaments, everybody's heard of proprioception. And so it's your body's kind of awareness of where it is in space. And so those ligaments have nerve endings that innervate them. If those ligaments are damaged in a sprain, those nerve endings will not necessarily function correctly, send the right signals to the brain and to fire certain muscles to help stabilize the ankle. And so if an ankle sprain is mistreated, delayed treatment, patients don't follow up, those types of things, it does put them at risk for this chronic instability because they're more at risk for that ankle being able to twist and roll with less force because of that lack of proprioception. And so when that happens, when the ligaments get all stretched out chronically and they have the loose, weak ankle that's painful, those will then turn into surgery. Expected outcomes, generic answer, it's 3 months for soft tissue healing, 6 weeks for bone healing. So, I'll get patients that'll come in frustrated that they have so much pain at 3 or 4 weeks out, and we have to have the discussion with them. Hey, this takes some time. These soft tissue injuries do take a while. The old adage, it's better to break the ankle than sprain it, is not really true because a lot of times these fractures will require surgery. And so really the soft tissue sprain is still going to be a better injury to have because there's no surgery involved with that. And again, without appropriate treatment, it can take an extreme amount of time. I had a severe sprain as like a 4th-year resident working, countless hours. I didn't do any therapy or anything like that. And I remember looking at my leg in the mirror and I'm like, what happened to it? So I just forced myself to get back on a treadmill and slowly build it back up. But it takes time and it takes a while the longer you wait. I like to say that, the longer you're immobilized, it's a cruel trick nature plays. If you're in a boot for 2 weeks, you're going to see atrophy in their leg muscles. And it takes about 4 weeks to get that back. So I basically tell them it takes double the time to get the strength back that it does to go away. So, it's important to immobilize, but at the same time, we want to get folks moving. So how do I manage ankle sprains? Grade 1 or 2, I'll get them in a brace, start some therapy. Range of motion is very important. The RICE treatment always. Grade 2 or 3, typically we want to try to give them some more support, more stability. Let them walk on it if X-rays are negative. If there's nothing grossly broken or displaced, or you're not worried about any kind of tendon tearing, you're not going to hurt anything by letting them put weight on it as they can tolerate in a boot. The whole RICE thing again. Range of motion for me is good because it maintains that joint motion, but it's in a more controlled fashion than trying to walk on it in those ligaments or then trying to stabilize the joint. And it also helps decrease swelling. So if you can get that patient moving the ankle, you're also firing those muscles that help pump the venous blood back to the heart, and it decreases swelling. And so as soon as patients seem to get better, see them 2, 4, 6 weeks, depending on how long it takes for them to recover, then we get them started in therapy. And I'd say 98% patients improve with this algorithm. By 3 months, they're all doing fairly well. If any time with rest in the boot, after starting some therapy, things just don't seem right, or if they have symptoms or mechanical symptoms concerning for a loose body or something like that, we'll get an MRI. But it's very rare that I get an MRI in an inversion ankle sprain if I know the mechanism and their exam is consistent. A lot of times the first time you see the patient, it's difficult to rule those things out, but as long as there's nothing grossly wrong, you're not going to cause any harm. And after some rest and immobilization, sometimes these folks will demonstrate, these more specific findings. The other thing to keep in mind that I see not infrequently, but not all the time, is somebody that just doesn't seem to be getting better. They don't have any kind of mechanical symptoms for a loose body or a cartilage injury. When I get the MRIs, a lot of times I'll see some bony osteoedema. It's just like a bone contusion. And so these folks, even though we've immobilized them in the boot and they're not making progress, a lot of times the MRI will show that. And as I like to describe to them, it's like you got punched in the arm and you're punching it every day with every step you take, and it's going to take a while for that to go away. And so those folks will actually make non-weight bearing for a period of time to let that calm down. So that's something else to keep in the back of your mind and your toolbox. So now we move on to high ankle sprains. An article out of JBJS in 2014 shows the anatomy. You can kind of see how the fibula sits in this little groove on the tibia called the incisura. You've got your anterior inferior tibiofibular ligament, your interosseous membrane, your posterior inferior tibiofibular ligament. And basically what I like to describe is, and so what is the purpose of syndesmosis? So it prevents diastasis. That means the fibula bone being pushed away from the tibia bone due to the axial load of the talus. So that talus wants to push up and separate these two bones. And so when these patients have these injuries, whether they're grossly displaced or not, even subtle ones, they'll have pain with axial loading. And so the fibula, the syndesmosis allows some rotation and some translation of the fibula with ankle dorsiflexion and plantar flexion. So if you look, the talus is wider anteriorly. This is in the front and in the back. And so as that ankle comes up, that fibula has to kind of rotate and translate posteriorly with ankle dorsiflexion, plantar flexion. It kind of internally rotates and translates anteriorly. And so the syndesmosis is a dynamic joint, not a static joint. And so those things keep in mind. So how do you make the diagnosis? So the history and mechanism of injury, very important. Any kind of external rotation mechanism, you've got to be concerned. Where do they have pain? Classically it's over the deltoid, the syndesmosis, sometimes the proximal fibula. Your physical exam findings, your stress testing, X-rays. Are there any gross asymmetries between the contralateral side or even on just the involved side? Is there any widening? And then stress tests and advanced imaging. So all these things come into play. So again, it's a rotational injury, external rotation with some dorsiflexion. There does not have to be an ankle fracture. However, it's exceedingly rare to have this without an associated fracture somewhere along the fibula or the medial malleolus. So anytime a patient has a rotational ankle fracture, you always got to worry about that. Or patients with continued pain after what we considered an ankle sprain, if we don't know the mechanism. So one of the things that I hear frequently is, if it's an ankle sprain, it doesn't get better, you got to worry about the high ankle sprain. Well, that's not necessarily true. That's why I keep harping on the mechanism. So Sports Medicine Journal back in 2002, they looked at 25 patients with MRIs with these injuries. And so they showed syndesmotic involvement, typically an external rotation mechanism does not have lateral ligament damage and vice versa. So really the mechanism kind of clues you in onto what their potential injury is. How do you diagnose this? So, you've got a nice MRI axial cut here where it shows damage to the AITFL. Normally on a ligament, a healthy ligament is going to be a nice black solid structure, and so it's kind of grayish, and you can see a little tear through here. They've got the nice positive arrow sign. And then the other two things that I do frequently is the squeeze test. So you're basically compressing the tibia and the fibula here, and you want to know if if the patient is getting any pain down here, which would be consistent with some instability of that syndesmosis distally. At the same time, the other test is the external rotation stress test. You want to flex the knee to 90 degrees, externally rotate the ankle while stabilizing the leg proximally, and that can be indicative of a syndesmotic injury. So the other thing to keep in mind is pain more proximal in an inversion injury. So here's an example of a Mason-New fracture, right? So if somebody has an external rotation mechanism, don't forget to feel the proximal fibula. You can see this significant widening on the X-ray down here. It's not present with everybody, but even down here on A and B, you've got a little bit of a difference here with a stress exam. You want to make sure that the pain is not over the lateral ligaments; it's a little bit higher, so that the level of pain is a little bit different. Which I thought this was a nice diagram to show that. And so if you don't know for sure, they have the external rotation mechanism. X-rays are normal. I always convert to a stress X-ray and then an MRI if I'm not convinced. So treatment, if it's unstable, we fix it. If it's stable, we can treat it conservatively. The problem with these things, again, is every step you take, just like those bone contusions, you're trying to diastase or separate those two bones. And so you're straining those ligaments, so it limits the healing. So these patients typically will do better with non-weight bearing for a period of time. Again, ligament healing, 12 weeks, it doesn't always require that much. But if it's unstable at all, you can see some gapping. You want to stabilize that to allow those ligaments to heal. If you're concerned about this, a syndesmotic injury, those are times when it's really good to refer to an ortho or sports medicine a physician to try to further work that up and make sure it doesn't need surgery. And so the last topic, Achilles tendon ruptures, it's a big hot topic in orthopedics. So the Achilles tendon is a powerful ankle plantar flexor. It's the weekend warrior. It's my age group, which is why I try to avoid some of these activities. And this is the one thing that I do where patients typically present exactly like they would in any stem of any test question we've ever taken. They're doing some kind of explosive activity. They feel like somebody kicks them or hits them in the back of the leg, and then they realize that they have a hard time pushing off. And so the tendon fails during eccentric muscle contraction. So the tendon is trying to lengthen while the muscle is contracted, and that's typically when this fails. So history is consistent, right? So it's going to be pretty much the same story almost every time. And the biggest thing is, I don't need MRIs. I don't order MRIs on the tendon itself when you get ruptures. I've got some videos here how I diagnose these things. So I get the patient in the room. Their history is consistent. I lay them on their tummy, and the first thing I do is palpate for the defect. So we can kind of see how I'm feeling the tendon, feeling the depression, the divot there, and then feeling the tendon again. And then everybody knows what the Thompson test is, where I've got the contralateral leg that's non-ruptured and the ruptured leg. So you can see how the toes don't plantar flex at all with that. So. All right. So here's the other thing that I find interesting is the level of rupture will change how we treat this. So proximal tears, if there's a proximal injury, typically surgery is not indicated. And basically the reason is you've got a lot of times you'll get a rupture at the gastroc muscle tendon junction, kind of at the soleus, Achilles junction. That's a little bit more questionable for repair. Tears in the gastroc up here. The reason is you can't really sew muscle back to tendon very well. And so really the only place that we would repair these is down here at the tendinous zone or the tendinous area where the watershed region is found. Obviously, everybody knows what watershed region is, where the blood supply is less than optimal and then tendon healing is a little less than predictable there. But that's when I do get an MRI. If I'm concerned about a higher rupture, I don't feel that divot in the tendon, I'll get an MRI just to see if it's something that's a little bit more proximal. And so you can only repair tendon to tendon when it's indicated. So that's another hot topic now. So, there was a study done in 2010 when I was a resident in Canada where they looked at conservative versus surgical treatment for these injuries. And they showed fairly similar outcomes of the non-op treated patients and the surgically treated patients. The only thing they found was that there was a higher risk of re-rupture in the non-operative treated group versus the operative treated group. And obviously, there were no surgical incision complications in the non-operative treated group. But if you look, there was only 3 ruptures versus 2 in 144 patients. So, I think I'd take that with a grain of salt. A couple meta-analysis, systematic reviews. They talk about maybe doing the minimally invasive percutaneous repairs of the Achilles tendon with accelerated rehab. But really, in the end, there's not a big difference between non-op and operative treatment. The caveat to that is, though, if you're going to do non-operative treatment, you have to start that immediately. So if it's delayed 2-3 weeks down the road, doing non-op treatment is a little less successful in the literature. And so how do I treat these folks? The first thing I do is I get them in a boot with the Achilles wedges. So you can kind of see how the toe is plantar flex. You're basically trying to shorten that tendon and get those tendon ends to approximate. And then you get them in a boot and immobilize them. Now, the other thing to keep in mind, if you do that, it gives you the opportunity to go non-operative or operative, depending on what the patient decides to do. And so the other thing to keep in mind is that if the foot is held in plantar flexion in a boot, and even if they're walking on it, it does increase the risk of a DVT. And I've seen that once before. But I get patients on at least aspirin if they can tolerate it to try to minimize their potential for a clot, and then proceed forward from there. So if it's surgical, we typically do that within the first 3 weeks, ideally within the first 2 weeks. Beyond 3 weeks could alter the plan. So if I've got a 25-year-old basketball player who I just saw is 4 months out, so you can't do a primary repair. That tendon retracts, it scars, and you can't cover that defect. And so typically, greater than 3 months, defect greater than 3 centimeters, we're looking at doing some kind of a tendon transfer. So if you look where the Achilles attaches back here, we can come in and take that FHL, release it back here in the tunnel, and then just transfer it just the anterior to the Achilles, and I then sew it side to side. Basically, that FHL will hypertrophy and gain strength, and basically help that Achilles strength. Questions about any of this stuff? Oh, I see we got 2. Dr. Berta, if young women with chronic sprains, do I discourage them from certain types of high heels? Well, I guess yes, especially if if they've got chronic instability and we fix it, we make it tight. The problem is can we keep it that way? And that takes some patient engagement and assistance to do that. There was a cadaver study done in 2020 where they looked at native ligaments, testing the strength of them, and then they repaired the ligaments like we would do in a standard Brostrom repair. And what they found is that CFL ligament stretches out first. And I've seen that myself. I think I looked at about 350 patients a couple summers ago, and there's about a 3.5% incidence of that CFL ligament stretching out. And I do see it more in females. And so when I do these repairs on folks, I tell them, we got it tight. We've got to keep it that way. So I tell them to avoid high heels if possible. Wear the brace with any kind of activity where there's any uneven ground, side to side movement, not because they need it, but to protect the repair. But if they've got chronic instability and they've got chronic pain, typically those are going to end up with surgery. We got another question. What is your return to sport protocol for a significant ankle sprain? Well, obviously, when I get the athletes, I take care of the OU athletes as well. When they have an injury like that, I want to rest them as little time as possible, because obviously the longer they're in a boot or immobilized, the more weakness they have, and then the longer it takes to effectively rehab that. And so, I'll see those patients every week or every 2 weeks until they have really calmed down and have really decreased the inflammation, the swelling, and get them started in therapy right away to try to get them moving and lose as little time as possible. And obviously, we've got them braced or taped. There was a study that showed no significant difference between bracing and taping, but depending on the level of athlete. I typically recommend a brace that's probably a little bit more consistent unless you have some kind of athletic trainer who's very skilled in doing that taping on a consistent basis. How long is recovery for Achilles tendon rupture? So interestingly enough, they're both fairly equivalent. I do treat a lot of patients non-operatively for Achilles ruptures. I do warn all of them that if they end up with some significant weakness At the end of that non-operative treatment, we can always take that FHL tendon and transfer it and provide them some strength. But it's typically 2 weeks non-weight bearing in a boot, if non-op, and then I start therapy at 6 weeks, functional rehab protocol. And usually by 8 weeks, patients are doing better. You can feel that tendon healing in. You don't feel that defect anymore. And they seem to do pretty darn well. Surgically, they're non-weight bearing for 2 weeks after surgery, and then in a boot and starting therapy right away. And it takes about the same amount of time. I tell patients it's a full year recovery for any surgery or even a non-op treatment of an Achilles. So, you're looking at 3 months for the ligament, the tendon to heal. And then I kind of unrestrict them a little bit after that. So I'm waiting for that 3-month soft tissue healing mark. Another question here, at what point do you think about the sinus tarsi syndrome, especially for recurrent sprains? Sinus tarsi syndrome for me is more of a flat foot type of disorder where that foot is, that posterior tibial tendon, that medial column has failed and that foot is kind of swinging out and you've got impingement in that sinus tarsi. And so for me, sinus tarsi is not necessarily associated with recurrent ankle sprains. So unless they have an associated flat foot, which we did a study on that as well. We looked at that, and it's about 25% of patients have some instability associated with a flat foot. So I think it's a separate issue, but it can be related. Another question: are flat-foot individuals at increased risk of Achilles tendon tear? Not necessarily. However, as that heel falls into valgus and that foot flattens out, that does shorten the Achilles tendon. And so for me, the Achilles tendon ruptures because of a tension imbalance between the two muscles that create it. The gastrocnemius and the soleus, they both send tendons down and they merge to make the Achilles. And there's a tension imbalance typically between the gastroc and the soleus that does increase the tension. So I'm not sure that a flat-footed person is at more risk, but it does change the tension on the Achilles. So, again, the Achilles ruptures, typically it's that eccentric explosive activity. And so it depends, flat-footed individuals typically have some posterior tibial tendon pain. It's usually a different patient population. So not something I typically worry too much about. Next question, what about earth shoes and Achilles tendon weakness? You'd have to explain to me what earth shoes are. I'm not sure, Dr. Berta. I don't know.
You have another question in the chat.
Okay.
I have learned that 70% of the sprains do not fully heal back to their prior injury strength. Thus, these patients are more likely to sprain again. Is this outdated information? If not, how do you tell a patient to prevent this?
Well, I think it depends on the number of sprains they've had previously. So everybody on this call has sprained their ankle on more than one occasion. So if there's any chronic instability, they might not heal that most recent sprain, but it's the first time sprains, if they're managed appropriately, they usually do pretty well. So I think it depends on a little bit more information than just the isolated sprain. So if you ask the patient, hey, what sports did you play in high school? What did you do? They pretty much all sprained their ankles multiple times before. And this kind of one big sprain kind of tips them over the edge. And, you get to 3 months and they're still struggling with it. And you can pretty much chalk it up to, they probably had some chronic instability prior to this new acute injury. Helpful?
Yes, you have a couple more questions. Or the Dr. Berta responded, the shoes with the heel is lower than the rest of the shoe. Those are the shoes.
Yeah, okay. So I don't think it contributes to weakness so much. It is going to stretch their calf out. I think, the big reason I think people develop that equinus contracture that puts them at risk of the Achilles rupturing and these issues, Achilles tendonitis and so forth, is because of the shoes that we wear. Typically the heel is higher. And if you wear that for a while, eventually that thing is going to shorten and compress. So earth shoes, yeah, I'm too young to know. No, I don't think it's going to contribute to Achilles weakness.
Any additional questions? Oh, there's no. Nope. Thank you very much, Dr. Cheney.
Thank you.
If I can have you stop sharing, you're perfect. Our next speaker is Dr. Mark Gittins. Dr. Gittins?
There we go. Well, good evening. Tonight, I'm going to go over some highlights on a topic none of us really like to talk about or even have, but it's certainly one that is extremely important and can be life-threatening and life-saving if you do the right things. And that's going to be something that we call PJIs, or periprosthetic prosthetic joint infections. So we're going to talk about that a little bit and some of the current ideas on that. Some of my co-authors that worked on this project this last year through the Orthopedic Foundation. So I'm indebted to them and all their hard work in this. So my disclosures, none of these are really relevant except my work with Next Step. And we've done some of the research, which I'll show at the end on some of the ideas that we may be coming up with. So what it really is, PJI, periprosthetic joint infections are really infections that involve the joint prosthesis and the adjacent tissue. So it really is a host issue. It's not something that's really simple. It involves some glycocalyx. It involves what the patient looks like, what their soft tissue composition is. So there's a lot that goes on there. It's not just one issue. So this is kind of how they present. It looks pretty, oh, this is not a big deal. This right here is a disaster. This person is fighting for their limb, believe it or not. This person is fighting for their life. The statistics would state that this issue that you see before you has probably a higher chance of mortality than a colon cancer. So it's something that you have to take seriously and you have to treat aggressively. So it really is the top of the volcano, and below this little spot right here is a world of hurt, world of infection that's contaminating the soft tissue and the implant. So don't be fooled on this. Somebody with an implant has this is really needs to be taken care of aggressively. The problem that we have with prosthetic joint infections with these PJI is that it's increasing over the last 15 years. We look at this study, we've seen both knees and hips increase in the rate that we're seeing them. What this means to our healthcare and the dollars that we all spend in our tax for this is that it's going up. So I mean, we're seeing significant dollars going towards the treatment in the U.S. budget. What's this mean to the individual patient? You know, somewhere around $30,000 per episode between hip and knee arthroplasty, and at least 2 surgeries. So to work on this, it's at least 2 surgeries for the patient. So there's some risk that goes with it. So it really is a significant issue for these patients. When we look at our current treatments, you can look at antibiotic suppression, and it really just doesn't work. You know, the patients all wish they could have it. Can you just give me a cream? Can you just give me some pills? And it's really been shown to be ineffective, and actually we get into more trouble with this. The only time that I'll use that is, you know, some type of end of life issue, and the patient is really towards the end of life, and that we're really not trying to clean this infection up. We're just trying to keep them comfortable. So that may be the only time that we would do suppressive therapy. The DARE procedure you might hear is really the debridement, antibiotics, and then the implant retention. This one you have to use caution. You are daring and using this one. It can be successful, but most of the time it's not. And it really depends on what organism we're dealing with and the virulence of that organism, and then how long the organism has been there. Obviously, the longer it's been there, the worse this is going to be. So you got to be careful on this. You need to get these people back to surgery almost immediately within the next day to try to have some success in doing this. Single exchange arthroplasty, more common in hips. It's more common in hips because we have a better blood supply in hips, right? We have a better soft tissue coverage. A little more common in Europe, but they'll try to do these as well. It does save the one surgery. The 2-stage exchange arthroplasty, that really is the gold standard. And basically that's taking out the components, putting in some type of spacer, usually some type of methyl methacrylate cement spacer that is impregnated with antibiotics. Arthrodesis, you confuse the joint, taking out the implant because that's where the bacteria are hiding, but you do get an increased recurrence. And then ablative surgery, amputation, usually is held when we've tried other procedures and have been unsuccessful. That's really the treatment that we have in taking care of these. None of those are really good things. So how can we really help these patients? And I think we need to just kind of think differently on how we've done it to help these patients. Certainly doing the preventive measures to prevent prosthetic joint infections is much better than the cure. The cure takes at least a couple of surgeries, it's extremely expensive. And even with that, you're flirting with mortality in these patients. So we've really done a lot of work and studies on this. And I think we have a much better handle on how to try to prevent it. And it's really working on the optimization of the patient and the modifiable patient risk factors. Something, if you look at Zardy's work, something as good as diabetes. You all treat that every day, and it's a lifelong struggle with these people. But even though the patient is in pain, and with every one of these factors, the patient's in pain, but you have to coach them and get them through and get them to the right specialist to optimize them. So with the diabetes, we got to get that A1C down to 7 or below. That's hard for patients, but it just has to be done. If not, we're working on these infections at a higher rate. Immunosuppressive treatments and joint infections. So if the person's a rheumatoid patient, we're going to have to get them off some of their immunosuppressants. But the biggest thing we see day in, day out is people injecting joints that are ready for arthroplasty. And that basically puts them on the sidelines for 3 to 6 months. So I don't care really what it is, whether, the most common thing is steroids, but it really does hurt the patient. And it increases their immunosuppression of the joint, increases their infection rate, increases their osteoporosis. It actually accelerates their arthritis. So I really don't see in these end-stage patients, once you look at their x-ray, you can see that they're basically grade 3, grade 4 arthritis. I would probably hold off of these because we know we're hurting the joint and increasing their infection rate. Tobacco use. We're one of the more liberal states when we go to the hip and knee surgeons. A lot of the other states are actually testing the patients for nicotine prior to surgery. The insurance companies are, because they know the results are worse and that the implants fail. They become loose, and then they have a higher infection rate. So we certainly need tobacco cessation in addition to the immunosuppressive, avoiding the shots in the joint, and working on their diabetes. So here's one of the ones that we're afflicted with in Ohio. The obese patient. Certainly, we at the last hip and knee meeting, we know that most Americans gained about 17 pounds during the pandemia that we've all been living with. But you can see that also the patients that got in trouble with the virus were the same ones that had some of these issues. They had immunodysfunction, pulmonary function issues. So, if it affects with the virus, it affects us as surgeons. So we know that getting this BMI to 40 or below. I had one insurance company knock off a patient. They said they could not proceed till they got him down to 35. So the insurance companies are wise to this. Why? They just care about saving money, but it really is the best thing for your patient. Now, this is hard. There's no doubt. Some of these people are really struggling with the weight challenge and the diabetes. We just got to get them to the right people. We got to, if they need weight management, then they need it. If they need their primary care seen more frequently in a diet, we got to get all the resources that we can to get this done. But proceeding with surgery just because they have arthritis is really heading into a gauntlet of problems. And certainly we just have to take the time. We've been able to counsel people into 100-pound weight losses before. You just got to see them. You got to counsel them. You got to get them in the right area so that they're optimized for the surgery. Opioid use, again, some of these people have been on pain medicines. They've had shots. Any type of opioid, believe it or not, actually increases their infection rate. I don't know the mechanism, but it has been shown in numerous studies. So we got to get them off the narcotics. We got to get them just the time and all that type of, again, to optimize the patient. Anything we can do to prevent this is going to be extremely important to this patient's overall outcome with this total joint, which really can be remarkable in what they're able to achieve. Things that we can do preoperatively. So some of the literature that has come out is certainly the drug of choice that we use, and we try to get it in within the hour of surgery, is cefsolin or ANSEF. Some recent studies have come out. If the patients identify themselves as penicillin allergic, quote unquote, patient identified, the treatment still should be this ANSEF. We're having to re-educate some of our staffs in the hospital because, back in the day, there was some thought that that there was a crossover between penicillin and cephalosporins, and when you do the meta-analysis, the risk factor of having an infection is much higher than it is for a crossover infection. And most of the time, these people are not allergic to penicillin. It was a childhood rash, usually because of someone who with some type of viral exanthem. If you really are worried, the current recommendation is that the patient should go to see somebody in the allergy world, to see an allergist, and have actually skin testing before we choose an inappropriate antibiotic. We want something that's bactericidal, not bacteriostatic. And by all means, this has been the drug of choice that we've had. Other treatments that can be used is we can use mupirocin ointments. We usually use those nasally. If we know we have carriers in the household, we can have everybody get treated prior to surgery, the week before surgery. So this is something that we do. You can also use betadine swabs. We use that sometimes in spine surgery, but mupirocin has been a pretty good ointment that we use preoperatively in the nares. Surgical factors, there's a lot of factors in believe it or not all surgeons and surgery teams. I usually look at them as teams are created equal. And so asking questions about how long the surgery takes, what's the rate of hematoma, what technologies they're using to help them is really, really important. So the longer the wound is open, basically, the higher chance of this infection rate. Some of the technologies, like you can see down here with robots and stuff, are making these things a little quicker. The newest thing that you're going to be seeing, we're doing a little bit of work at the Orthopedic Foundation on, is the augmented reality. So basically, the picture is going to come up in our goggles, as well as the corrective measures in our goggles. So we're doing a little bit of research on that's starting right now. So that's the next thing to come. That's actually most likely going to surpass robots or work in conjunction with them. But again, the surgical factors are doing this well, doing it in a time efficient. Don't keep the tourniquet up. Don't have the wound oozing afterwards. And there's ways we can try to manage that. One of the ways that we've done this in this Buchalter work is that we use a vancomycin powder in the wound closure at the different levels. So we just put some powder in there. And then probably the easiest thing is, prior to doing the vancomycin, right before closure, we really wash out the wound with this good old betadine that we've used. And so we have a sterile process that. The key in that is having a lot of fluid, and then the time that the joint is exposed to that. So you just don't do a quick wash like you would wash your mouth out. We need somewhere almost at 3 minutes of betadine contact time. If you can do that, there's a significant scientifically that we can reduce the infection. So these are all the intraoperative things: being quick, being good with the tissues, using betadine, and then throwing the vancomycin powder on there prior to your closure. So that's something we can do. And again, that's the current recommendations with the current literature. To help with the wounds, the TXA that we use, the transischemic acid, I think that is really, really important. It has been a game saver. It's certainly been a transfusion saver. We just don't see transfusions anymore now that we use this. So we use it in an off-label fashion, but we've been using it for a long time, and so have other surgeons. So the route of administration have been shown in the Journal of Arthroplasty really not to matter, whether it's oral, whether it's IV, or whether it's in the wound. It seems to have the same efficacy. One of the questions that we usually hear about, and we've had to educate anesthesia on this, is, oh, they've had cardiac stents, they can't have it, or this person's had heart problems in the past, they can't have it. They've had blood clots in the past, they can't have it. And there's been some studies, specifically at a Mayo Clinic in the Journal of Arthroplasty, show that's incorrect. This is not a clot former, it's actually a clot stabilizer. And so you have to look at the mechanism of action. It has really, really poor bioavailability. So you do need to get the full gram in there in plenty of time. But it is really a game changer on how it works with these joints and the wounds. As far as dressings, when we get to the dressing layer, certainly we're seeing more and more improvement with the silver impregnated dressings. So if I don't have any choices, that's the choice I will use. But here's really the current state of the art using, and this is what we saw in 2016, and we've had this published numerous times. Some type of negative pressure dressing seems to have a decreased infection rate and a quicker healing wound rate. So these stay on until they're basically seen in the office in 10 to 14 days. So sometimes we'll get calls from the ER, they're not familiar with them, or somebody at the urgent care, and they go, it's not working, there's nothing coming out of the drain. And they think these are wound vacs, and those are used for chronic infections, and we do use those. But these are really negative pressure wound therapy. And so basically it just puts a suction over the dressing, and we don't really want to see a lot coming out of it. So they're able to shower with these, and again, it has decreased the infection rate significantly. So something that you may see in your office, and if you have questions, you can always just call your surgeon, and we can address that. So here's some of the research that we talked about, and some of it has to do with some nanoparticle research. And so the more you research, and I've tried to become more and more educated on the nanoparticles, it is really interesting, having these immunizations that we've all had with the mRNA. That is a nanoparticle that they're using as a carrier. So it's been really interesting. Even in the pandemic, this has been done. The nanoparticle we're talking about that we've had some interest in, it seems to be working, is silica oxide. And this is something that we can coat the implant, because if you look at it, the implant gets a slime layer or glycocalyx, and that's where the bacteria hides. So that's why we have to do these exchanged arthroplasties. But if we can coat the implant, which can be coated on the back table, but most likely as this comes to market, it's probably going to be coated in the factory. Then we have this chemically inert, very small 5 nanometer particle that coats onto the implant. The way this works, instead of being chemotoxics, because that's how we normally kill bacteria, this is basically a surface property that still makes it cytotoxic to the cell. And the way that works is through the cell wall. Well, we all know that's how the cephalosporins work, is that they break the cell wall down, and that's the difference between basically a cytotoxic versus, lysosomes are worked with the antibiotics that are not cytotoxic. And so we really want to break the cell wall down. This is a fairly inexpensive coating, and can be applied to a lot of implants. So I'll kind of show you some of the research that we've done on this. So this is what they kind of look like with the nanoparticles. And again, you can see the barbs on there, and that's how the cell wall is broken down. It's a mechanical, it's not a pharmaceutical reaction. The proof of the concept, this is basically Staph aureus, so it's methicillin resistant Staph aureus, and you can see this on a blood and a chocolate agar. And as we put the particles on there, you can see that there's no growth over the areas where the silica oxide is done. So then we did more tests, and we coated some implants, and this just basically shows these pins. So it's interesting, pins are round, and then they have a helical portion that drills into the bone. So it's a somewhat of a complex structure. And we could see the ones that were coated with the nanoparticles did not grow. It's perfectly clear. The ones that were not coated, you could see it grew. And that was our control pin. And again, this was methicillin resistant Staph aureus. So then we looked at it, and we coated these washers, and we put them on the augers again. And we wanted to make sure that this wasn't going to leach out and hurt normal tissue. So you can see this with a control and a non-control, that these were placed, and there's no inhibition, there's no zone of leaching. It pretty much just stays right where it touches. That's where the inhibition of the Staph aureus is. These are some electron micrographs. And again, this is important because these were on the pins that I showed you before. And you can look at the coated side on the left, over here on the left side, and you can see the pin is a complex geometric structure, and the geometry has these helixes that go around it, and you see no staph on these at all. The control pins, you can see the staph hiding. It just takes one of these bad guys to start an infection. So you can see underneath the ridges, the staph likes to hide. So it was pretty amazing what we're able to do to not get the staph to actually stick to the implant. So in conclusion, the infection rates and the cost due to infection is increasing in the United States as well as the world. It's certainly taxing our healthcare dollars. we need to probably work more on prevention and treatment, although we're going to continue to work on the treatment part. Prevention certainly has the mainstay of what we need to do. These nanoparticulates may be a way to prevent the infection on hardware implementation. We've certainly been able to prove that it does work against methicillin-resistant Staph aureus, and it can be fast, easy, and at this point we think it's safe, and certainly it's cost-effective. We certainly need to do more testing, and that's what we'll do at the Orthopedic Foundation. We're doing testing on the coating against other bacteria. What other bacteria does it work against? What's the frictional testing of the coating? Long-term stability, how long does this coating stay on? When does it become ineffective? And then we'll have to check the in vivo testing of these pins. Does it weaken the pin against the bone as we pull it out? And then how does it work against other materials such as mesh? For hernias, mesh that we use in tendon repairs, the instruments themselves, if we coat the instruments with these, and then suture devices as well. So with that, more to come as we do our work on that, but I thought it was a good topic. I appreciate your time, and I'm happy to answer any questions if you go to your Q&A box. Dr. Bullock, right off the top, with some dentists are recommended taking prophylactic antibiotics indefinitely. Great question. And prior to this last meeting at the hip and knee surgeons, I was in that ball game. And now I think the studies are really showing that it's not necessary. So I'm not giving my patients any more antibiotics, although I had done it for a decade. So no longer am I requiring the antibiotics at that point. We're actually we're trying to be real good stewards of our antibiotic use. And it looks like at this point from the retrieval studies and just overall patient surveillance that it's really not necessary. At this point, we're not giving our patients antibiotics in a prophylactic manner for infection. Now, if the dentist wants to do it, we let them do it, but we do not do it. So that tide just started happening to turn in November this last year. So it is somewhat of a new topic. Is there a difference in incidence of infection between inpatient and outpatient surgery? It's a great question. And the answer is yes. There is a less incidence of infection in outpatient ASC surgeries. It really has to do with the host. It has to do with optimizing the host, and it does have to do with how long they're in the environment. So obviously, if you're staying overnight, you're in the ICUs. The ventilation is different. So the answer is yes, it is less in the outpatient world. Any other questions?
I think Dr. Berta is asking if insurance covers that.
Does insurance do what?
I think she's asking if insurance covers that.
It covers what, the coatings or the treatment for infection?
I would think so. I'm not sure.
So
that's what I think she's
the nanoparticles with the silica oxide, that's yet to come. We haven't even put that to the insurance companies. We got a little bit of work to do yet this year to get that to the market. I'm sure they're going to want, you saw it's about $30,000 a patient for an infection treatment right now. So anything we can do that's going to save them money, I got a feeling they're going to be on board, but we still have to do some of that testing that I just showed you that we're working on through the foundation.
Any additional questions? Thank you, Dr. Gittins.
All righty. Thank you very much. Guys, have a great night.
Our next speaker is Dr. Benjamin Szerlip. Dr. Szerlip?
Hi, everybody. And thank you, Heather, and thanks to everyone who's participating in this meeting. It's a pleasure to be here with you guys virtually. I'm going to try to share the screen. And please, Heather, feel free to interrupt if any questions come in. I would love this to be as interactive as possible. So I thought I'd tackle two very common things that patients may have questions about, or what we're going to see in shoulder practice today. And that's how to manage partial cuff tears. And then what are some of the new advances in total shoulder replacement or shoulder arthroplasty? I think I have half an hour. We'll try to be going through this relatively quickly. Okay, disclosures. These are some of the companies that I do work with and help with surgeon education. None of these topics will be relevant to those disclosures. Background, I grew up in Mount Vernon, Ohio, 45 minutes north of Columbus. I went to the College of Worcester, stayed in Ohio for training, including Ohio University College of Osteopathic Medicine, and did residency up at university hospitals. So definitely consider myself an Ohio boy. Then I moved to Houston for a fellowship that I absolutely loved in shoulder to elbow surgery. I was some of the leaders in that field, and stayed and practiced in Austin for 6 years after that. So rotator cuff tears, I'm sure everybody has seen them, encountered them. How do we compare apples to oranges? So essentially in, ages of 60 or over, if you took 100 people off the street and gave them an MRI, approximately 50% of them would have some kind of rotator cuff pathology. I don't think people are aware of that, and not all tears are even bothering patients or symptomatic. Most of the tears, they can be partial, or they're not significant full thickness tears to where they're causing limited range of motion or pseudoparalysis, but they can be painful and eventually become symptomatic. So how do we differentiate these, the partial tears that don't need any treatment at all, that's just a sign of aging, or I call it having gray hair, versus how many of these patients need to be treated with conservative modalities or possibly surgery. So MRI is kind of the gold standard, partial versus full thickness rotator cuff tears. There's also the fact that you can have the location of the tear, whether it's in one of the four muscles, whether it's in the anterior cable. The size of the tear is a big deal in how retracted it is, the atrophy. And that's one thing that I think that all of us kind of need to focus on more is I use the analogy that if atrophy is if there's a lean piece of venison, for my hunters, they'll kind of know that, but that's kind of the perfect ideal young, healthy muscle. As we get older, or medical issues play a role, or there's a tear for a long period of time over several years, fat starts to replace that muscle. And that, think of like a really marbled ribeye or even a strip of bacon. So that fat is not as durable or robust for the patient's repair rates, or for the durability or healing rates of the repair. So in general, the best prognosis, they're acute tears. They haven't been going on for years. They're smaller, more mobile, they're meaning not pulled back and stuck and scarred down. There is minimal atrophy. The patient's younger. So we call younger under 75, but I tell patients all the time that some of my 75-year-olds are running marathons and should be on a Centrum Silver commercial. So, and some of my patients who are much younger are not in great shape, or their other health status, smoking, diabetes, kidney issues. It shows that in the data that actually that workers' comp claims can have a negative influence on some outcomes, but that's kind of out of the scope of this talk. But how do we define these partial tears? So is the rope completely pulled apart and torn off, or is there just some fraying on some of those fibers, is what I tell patients. And so they kind of divide it up into three easy grading systems. So grade 1 is smaller, grade 2, 25 to 50%, and then grade 3 is over 50%. And this is, if you look back down in the bottom right corner, this is back in 1990. So some of these findings are over 30 years old. So keep that into context. Let's see, next slide. So in 1999, 10 years later, that they did find that in the highlighted section, essentially, the outstanding results of prior studies of the debridement. So meaning if they just trim down some of those frayed fibers, that would be adequate. And their findings is actually it didn't happen. That recognition of the repairs, and maybe better to repair some of them in tears over 50% thickness. So this is what they found out. And I would tell you this data is a little bit subjective. It was determined by this paper and a couple other meetings where some of the experts got into a room together and said, hey, if it's over 50% torn, then we're going to repair the tendon. If it's not, we're just going to trim some of those fibers. So even though that's 20 years old now, 22 years old, that's still kind of the dogma or the status quo, if you will. very interesting. So the 50% rule, we kind of talked about that level 5 evidence. So not as much level 1 data on this, but it still kind of sticks. And you see that paper. So 1990 was the original paper where they defined these grades, and they're still saying it, 20 years later, that we should maybe consider repairing that partial tear, because one, it does help patients with their pain, and it helps prevent the progression to a full thickness tear, which could lead to atrophy or dysfunction, and a couple other things. So we talked about size, we talked about atrophy, and does the tear location matter? Well, it actually, we found out that it does. And so you see in here up in the upper right, there's a picture of arthroscopy where there's an articular sided tear. This is more of a bursal sided tear here you see on the camera, and this is intrasubstance or intratendinous, what we see on ultrasound here. So these do play a role. In fact, they found out that most patients with the bursal sided tears had a statistically significant higher failure rate. So when we see these articular surface tears, or we think that that's just part of the capsule, as you'll see in a Japanese study we have a slide on later, that they're different. They're not all created equal. So those bursal sided tears usually generate more pain for the patient, and they usually tend to progress to full thickness tears more often and more quickly than the articular sided tearing. So that's something to consider when you interpret the MRI with the patient and help them go over their treatment options. So we're trying to, this is one of the pictures if you're looking at the axial view. So we think that some of this stuff here, the label C is a capsule, and then this is actually the rotator cuff on the greater tuberosity, which we know makes up the 3 rotator cuff tendons, and the lesser tuberosity has the subscapularis. There is some argument that there's some crossover over the bicipital groove. Let's see. So this is the picture from the study from Japan. And when the articular capsule is removed, there's actually quite a significant portion for the capsule right there. And then the rotator cuff is located here. So if you see the articular sided tearing, that could be fraying of the capsule, which is not necessarily as detrimental or problematic for the patient as much as an actual rotator cuff tear at the footprint or at the bursal side. So something to keep in mind when we're all seeing these rotator cuff tears, and advising which patients on if they should pursue conservative treatment, including injections with steroid, injections with other things like PRP or stem cell options, physical therapy, all those other treatment modalities. So stemless shoulder replacement, is it a good idea? And this is one of my favorite websites, despair.com. It's entertaining when you're trying to procrastinate making slides. But it essentially mistakes. It could be that the purpose of your life is only to serve as a warning to others. Oftentimes, I think as physicians, we all feel that way when we're dealing with our complications or potential mistakes. So to start with, should we use a stemless or less metal in the shoulder replacement? We have to understand how we got there in the first place. And I think the big deal is like knowing your history, right? So we used to use long stems, as you see on this picture on the left, all the way down the arm. In some of these smaller female patients, that really was all the way down the arm. And then we put cement down there. And so this was kind of a little bit geographic, Europe versus the US. And this is published by my fellowship director. And this is all the way back in 2007. They say, hey, cemented stems work really well. Only 1 out of 137 replacements had loosening. So that's a pretty good statistic across the board. If any number needed to treat was that high, I'd be pretty happy. But these are some of the cases that I've encountered when somebody else put in cement down the arm, like I explained, and we had to go basically chisel it all out, regraft things with bones. And the new technology has helped with that a lot. But even 5 to 10 years ago, we didn't have all those things. So we had to create allograft reconstructions, had to use bone cement all the way down the arm, several cables. You had to pull out all the stops and essentially replace half the arm and not just the shoulder. So there is opportunity to improve and not use bone cement because of the potential risk for bone loss and the potential difficulty and frustration it can create with the revisions. So fortune favors the bold. This was literally a paper published approximately 20 years ago, and it's out of Mayo Clinic, and they said, hey, even though that we see 9.7 as opposed to 1 out of 137, we still believe that there's value in not using cement. So even though the complication rates from loosening in implants without cement are 10 times higher, we still think that's worth or justifies the possibility of trying to get better with this cementless or press fit system, where we just put the metal down in the humerus part. And this is where what I came to know and love when I was in fellowship. We did this study with Dr. Edwards and several other docs, and we took 118 replacement parts, and you see the metal as the evolution of shoulder replacements come along. It's a lot less metal. It's trying to preserve the patient's bone. And we found that it's actually the 2 to 5 year data showed that their loosening rates are going down. So there's some radiolucent lines, but there's no, there was no clinical loosening at the 2 to 5 year mark. If there was some loosening noted, there was a couple in the study. If you see 3 females, they required revision right away. So the numbers keep creeping down and people get better. Think about electric cars, if you will. People are obsessed with Tesla. It's a very common, conversation topic, but people don't know that electric cars have been around for more than a decade. So I think that all this technology and all this, common mainstream craze with electric cars now is because of all this technology and all this innovation that's been going on for much longer and behind the scenes than people think. So my question to you is, before we move on to no metal down the arm at all, can we at least agree on not using cement? And I think that that's where we're at in the year 2020 and 2022. So this is another paper we did kind of showing that if you put metal down the arm, it can make it more difficult to restore the anatomy. So we did this paper actually through OrthoNeuro and some of the docs up at the Cleveland Clinic. And there's stemmed arthroplasties and there's resurfacing. And so when you just do the resurfacing alone, it actually creates a deviation. So we not only had to figure out how to not use cement, but then how to use the stemless or the component that didn't have the metal down there, and then figure out how to appropriately or anatomically create that. And this is where we are today in 2022. If you look here, there's no metal down the arm, there's no cement. There's a lot of advantages to this. You're decreasing the operative time. You're decreasing blood loss for patients. You're also decreasing the amount of bone you may have to take for a future revision. They're also finding that if patients come into contact, have falls, have other issues, that their native bone is actually much better to absorb a fall or prevent a break or a periprosthetic fracture around there. So there's a lot of potential advantages, and it's taken 2 decades to kind of tease out, and it's super interesting. So this is kind of what we're showing you here. And then this is an example of what the model that we did the study with back in 2017, and then what has evolved. So we're using less and less metal. So the big deal is kind of understanding further where we knew where we came 20 years ago, and now we're kind of saying, hey, what do we have to make sure that we're knowing and understanding for the future to make these results successful, not only just 2 to 5 years, but 10, 20 years down the road. And it's kind of saying that when compared, the bone stresses between the stemless, the short, and the standard stem, the short-term outcomes are promising. Essentially, that having your own native bone down the arm or down the shaft of the humerus is more ideal. I would actually tell you from experience, this very nice patient, and this patient was climbing up into their kid's treehouse, and this was 10 days after the surgery. There was no bad intentions, but that patient fell out of the treehouse approximately 10 feet onto that shoulder, and so I was shocked to find out that there was not a fracture. Now, this may have just been lucky, and it's just the study of one, but it certainly does. Some of this study here and some of the other data lend to that. Having your own bone, there's a lot of potential advantages. And if we're just replacing that small wafer of bone about that big with the arthritis and where there's no cartilage, that again, decreases operative time, decreases pain, preserves the patient's bone, and heaven forbid they should need another surgery or have a fall, that they would have less complications or less requirements for revision. So what does the literature tell us so far? Moving into this, we say, hey, we can have a fairly significant confidence interval that while Stemless hasn't been available in the United States for as long, Europe usually has an approval process that goes through quicker. So we know that, over the past a couple of years, and these studies were done probably 3 to 5 years ago from now. So that should be updated. And there's essentially no humeral loosening there. There were complications. There were some problems. They were relatively minimal, but there were no loosening. So it's come quite a long way back in 2000 when they said, hey, we should just keep on cementing stems forever and ever and put metal and cement all the way down a patient's arm. So this is what we're aiming for. And this is an example of how you accurately restore. There should be kind of a perfect circle when you draw it around the patient's arm. And whether you're using a stemless implant or whether you're using a metal down the arm, you want to understand some of those anatomic principles and then the data behind it, and then some of the future studies that we have going down the road to help us be successful for our patients. This is one of my favorite quotes, and this is by J.P. Warner. He's another shoulder doc who is up in Harvard, and he started the Codman Shoulder Society. But he said, this is why they started the society, is to give me something different, for there is a chance of being better. And I think that's what we all strive to do as physicians, especially Dr. Gittins' most recent talk. So I just wanted to say thank you. And it's a pleasure to be here as always. Please, I'd be happy to answer any questions that come up in the Q&A session. And thank you so much.
Thank you, Dr. Szerlip. We have a question from Dr. Berta. If a patient is in a nursing home, if a patient is a nursing home care provider pulling and rolling patients to provide care, do you suggest that they stop and get workers' compensation or have them rehab for different training?
So I'm sorry, if they work in a nursing home, I want to repeat the question so everybody, if they work in a nursing home and they hurt their shoulder, is that what you asked?
If a patient is a nursing home care provider pulling and rolling patients to provide care, do you suggest that they stop and get workers' compensation or have them rehab for a different training?
That's an excellent question. I think that, and I'd be happy to extend my email or my cell phone. We could talk about it. It sounds like an actual particular situation. But in general, for this course, I don't think that we as physicians should, tell patients when they need to file a workers' comp claim. If it did happen at work and it's a direct result of work, I certainly think that's a very valid, very legitimate reason to file a workers' comp claim. So the kind of, off the record answer is that sounds very reasonable in that situation, but it would depend on some of the specifics. And then the second part of the question would be, should they rehab or try to find a position that is less demanding? And I would say that it's actually, I get to counsel patients for a living, and it's really fun and rewarding to see what matters to them and what makes them happy. And after a certain age, or if they have certain limitations, most patients do feel happier or more secure in their job if they're able to protect themselves. So essentially, they're not lifting heavy things, pushing and pulling, if they don't feel able, and they're going to potentially injure themselves. So as they get older, in their 50s and 60s, it's the exception to the rule and not the rule that patients are like, yeah, I'm certainly happy lifting 30 to 40 pounds on a consistent basis. Because one, they could hurt themselves, and two, as we all get older, they feel less job security.
Thank you. Are there any additional questions? I have a question. How many of the stemless total shoulders have you done?
So since that paper, we started back in 2018. And so we've put in over 200 at this point in time. We are currently studying that, but it does take time to say, hey, now we've done this and it's measured over, 5 years, 5-year outcome. But so we do look to Europe because they kind of had it approved for much longer. So we know that they have 10 to 15 year data that's showing that it's actually doing very well. So we put in over hundreds, and we know that it's lasting up to 15 years, and to be determined on how long that'll go.
Is there any reason why you wouldn't put in a stemless at this point?
Yeah, perfect question. There's still options. So we still, in the operating room, we still have an option to use a stem. And that would be in a case where the patient, we feel the bone quality wouldn't be able to just suffice at the proximal aspect of the humerus. So when the bone quality is poor, let's kind of imagine a patient with osteoporosis, or they're significantly older. That's when more metal may be a good idea to help facilitate or stabilize that implant earlier.
Thank you.
Absolutely, it's my pleasure.
Any additional questions? Thank you, Dr. Szerlip.
Absolutely, thank you.
Our final speaker for this evening is Dr. James Cassandra. Dr. Cassandra?
Hi, can you hear me?
Yes. You're going to want to share your screen and then go to your presentation.
Let's see.
There we go. You're good.
Does that look okay? Can you see
It does.
All right. Hi, thanks for having me. My name is James Cassandra. I'm orthopedics surgeon. I've done a hand upper extremity fellowship, and today I'd like to talk about a common condition we see. It's hand arthritis, and there's a couple of different varieties, and I'd just like to go through some common things that I see and discuss treatment options, surgical options, and some common types of arthritis. So let's get this started. So hand arthritis, the most common I see every day, all day. See it when I'm not in the hospital, on hands all the time. It's osteoarthritis. It's very common. Basal joint arthritis is actually the most common arthritis in the human body. So osteoarthritis, then next most common is probably rheumatoid arthritis. The medications over the last 20 years, especially the biologics and some of the disease modifying drugs, really decreased those patients that I see as a hand surgeon. In the past, a lot of these rheumatoid patients weren't treated with these type of medications, and their disease process advanced, and it led to significant destruction and led to the condition of rheumatoid hand. We'll go over that later. Gouty arthritis is probably the next most common arthritis that I see, very common with acute situations in the upper extremity, mostly the wrist, and the chronic cases can affect the hand and elbow. And then psoriatic arthritis is, arthritis can happen. I see a lot of patients with psoriasis, and anytime there's psoriasis, to keep in mind the condition of psoriatic arthritis is important. Gouty arthritis, let's deal with that first. it goes back to the 1600s. It's like the devil biting someone's big toe. It's painful. We call it the gout. The classic is podagra, is inflammation of the metatarsal phalangeal joint of the big toe. And I think with all the patients that I've seen over the years, the big toe is probably not the most common place that I see it. Other key locations are the ankle, knee, the wrist is common. And, in the chronic conditions, there's a lot of changes in the hand. It's basically uric acid is deposited and can lead to crystal formation. In 1679, this gentleman and Anthony van Leeuwenhoek characterized this as a rich man's disease. Usually kings or patients that are eating much better. So it's the elevated uric acid leads to crystal deposition into the joints and synovium. So it's related with different components. The dietary component's important. It's based on the purine metabolism. So alcohol, meat, shellfish are all common foods that are high in purines. And as they break down into uric acid, if that uric acid gets too high and can't be excreted, the crystals can form. So other health problems that can be associated with it: obesity, CHF, diabetes, hypertension, kidney disease, and like anything, there's a genetic component. Here's a example of acute gout. The joints inflame, there's swelling. It's a crystalline arthropathy, and there's uric acid deposition. The uric acid is deposited and these crystals form in the synovial fluid, and this leads to the inflammation, pain, and swelling and warmth, where the immune system comes in and causes the inflammatory response. These acute conditions, it's common in the hospital to see these where patient comes in, they have a warm, swollen joint, common in the wrist joint, the knee, ankle. As a hand surgeon, the wrist is probably the most common in acute gout. So the picture is usually painful, warm joint. You're always keeping the differential diagnosis, a septic joint, and working that up is very important. So, getting synovial fluid to helping make that diagnosis, ruling out infection is key. So if you tap the joint, get fluid off, and it's sent in a timely fashion to the lab, you see the monosodium urate crystals. They're needle-like, they're negative birefrigerant. That's always a board question or test question. It's unlike the pseudo-gout or chondrocalcinosis, which is more rhomboid shape and positive birefrigerant. And in chronic cases, if the uric acid levels build up in soft tissue, you can get the tophus or tophi formation. And what a tophi is, I think of it like a ball of gout. You get into it, it looks like a pasty substance of uric acid, and it very similar appearance to what Colgate toothpaste, the white toothpaste, looks like. It's real pasty and just gets peppered through soft tissue. So gouty arthritis in the hand, acute, there's pain, redness, stiffness, warmth. Chronic, it can lead to stiffness, deformity, and these tophis form. And you can see these massive masses on the finger. It can lead to soft tissue, bony destruction, and even skin erosion. So working these patients up, oftentimes history is very helpful, seeing if there's any family history or any prior history of gouty flare-ups, physical examination. Labs can be helpful, but uric acid, it's a limited study. Many patients with elevated uric acid levels don't have gout, and even if it is elevated, it doesn't mean it is gout. So it's of limited use. CBC, Chem7, sed rate can be helpful. You always need to rule out infection in these acute cases. And then that, tapping the joint or doing an arthrocentesis will be key to get that fluid off and send it for a synovial fluid analysis. X-rays can be helpful, and sometimes MRI, not just, it could give more information, but I don't think routinely has to be done. There's an example of radiographs of the hand and long-standing gout, something that we want to prevent. When we see something like this, it's late. You can see the erosion of the second metacarpal head and neck. It looks, like someone took a big bite out of it, and there's some periarticular erosion into the joint surface and soft tissue swelling. And oftentimes you get in and with the gouty tophi deposition, it can lead to even tendon and soft tissue erosion, which can complicate cases and closures and lead to infections sometimes. So the goals of gout are to, manage these acute gouty attacks. NSAIDs, usually my go-to is indomethacin, corticosteroids. Once you rule out infection in an acute case, definitely you can consider a cortisone injection into a joint. That can be very beneficial. You just, have to make sure there's not infection. Cortisone into a joint, especially an injection with infection, can lead to, worsening of the infection. Colchicine, something that can be given. And then we really want to prevent chronic gout and that chronic elevated uric acid that can lead to the uric acid deposition and tophi formation. And this can lead to tissue and joint destruction. So prevention is with diet, exercise, hydration, and medications. And sometimes these chronic medications like allopurinol or probenecid are kind of the old standbys. Usually allopurinol is something, and then some newer medications as well. Here's a picture, something we see in surgery. That's a gouty tophi coming out of the back of the hand. It eroded the extensor digiti minimi tendon about 50%. Sometimes it erodes these tendons completely. So surgical management on an acute gouty situation, most times we don't need to consider surgery. Occasionally, if that pain continues, we can consider something like an arthroscopic lavage and synovectomy to clean the joint out. But most times, an acute case managed medically will get better and can avoid surgery. But severe cases where there's large tophi formation, erosion into the joint, sometimes we start talking surgical intervention for mass excision, taking out the tophi, tendon reconstruction at times, or tendon transfer if the tendon's eroded, and we have to achieve better tendon or recreate tendon function, or arthrodesis or fusion of the joint, or other things that we consider. One thing, joint replacement may be possible, but if there's significant bone loss, like the X-ray I showed, that makes it more difficult. Next type of arthritis is related with psoriasis or psoriatic arthritis. It's broken down into different types. The most common type is plaque psoriasis. It's a common autoimmune disease. The plaque psoriasis is about 90% of the cases. You start seeing a raised kind of red, dry, scaly plaque. It's usually on the extensor surface, back of the elbow, on the front of the knee, the forearm, the back of the hand are common locations. So anytime a patient has psoriasis, you want to keep in the back of your mind psoriatic arthritis. 5% of patients with psoriasis can have psoriatic arthritis. It's a seronegative spondyloarthropathy. It's associated 50% of the time with HLA B27. It's an inflammatory arthritis. There's no cure for it, so managing it medically is very important. It can have long-term consequences. And here's a picture of a hand with psoriatic arthritis. And a radiograph with psoriatic arthritis, you can see some joint erosion, most notable at the interphalangeal joints, both the distal interphalangeal joint and the proximal interphalangeal joints. There's different types of psoriatic arthritis. Oligoarticular is the most common at 70%. Less than 3 joints are affected, and it's mild. There's a polyarticular version where it's happens around 25% of the time. It's more than 5 joints, and it can be disabling in half the cases. A very severe form is arthritis mutilans. It has severe destruction of the joints. Not very common. I don't think I've ever seen it clinically, just in textbooks. And there's spondyloarthritis that's associated with this, and also the distal interphalangeal joint predominant version, which is around 5%. And this is most notable with changes at the distal interphalangeal joint, and nail changes are associated with this. So some common features with psoriatic arthritis are swelling of the entire finger, a sausage digit on the right hand in the image. The long finger is kind of thick, swollen, almost like a sausage. Nails have changes. They have pitting, thickening, detachment. Leukonychia, or whiteness on the nail, can happen sometimes. And the skin, you have the classic red, scaly, itchy plaque. The psoriatic arthritis is an inflammatory process. The treatment goal is to prevent joint damage. So, you know, if these patients with psoriasis, you want to worry about any arthritic symptoms, and, you know, try to manage this and help. We want to prevent any joint damage. So to reduce and control inflammation, we have anti-inflammatories, disease-modifying agents, biologics, and phosphodiesterase 4 inhibitors. You know, when patients get to me, oftentimes they've been treated by their primary care physician or rheumatologist and have some of these on board. Sometimes they don't. With these patients, I often get a rheumatology consult if I'm suspicious for this. And I sometimes can do a cortisone injection to help with pain, and surgery sometimes an option. It's surgery for these, or it's usually it's not you don't jump right into surgery. It's usually more in the severe cases. And we're usually looking at something like arthroplasty and arthrodesis. And the goal would be to avoid surgery by controlling the inflammatory process. So here's some classic findings. You always hear the X-ray finding, pencil and cup deformity. This is kind of what it looks like with the erosion at the distal interphalangeal joint. The opera glass hand is on the right, where there's some osteolysis and spontaneous ankylosis, and you can see this through the PIP joints. So, you know, something like this can be very deforming and make it hard to perform daily functions. And the most aggressive case is the arthritis mutilans. It leads to loss of bone stock. There's collapse of the digit, shortening, and it makes it very hard to function, make a fist, grab things, or use a hand. Hand surgery, the goal of treatment here is to address the bony changes, preserve function, reduce pain, achieve stability, and correct deformities, and provide better function through doing this. Here's an example of a fusion of the distal interphalangeal joint. Next is rheumatoid arthritis. It's a chronic inflammatory disorder. It affects many joints. It may damage many body systems, so it's just not the joint. It can be the soft tissue, tendons, cardiovascular, it's an autoimmune disorder. In the joints and tendons, it's a disease of the synovium. So the synovial linings is where the main pathology is. So the joints are lined by the synovium, and then the tendons have the tenosynovium, which can be affected. The joints are tender, warm, swollen. There's joint stiffness, fatigue, fever, decreased appetite. Usually early in the disease process, the smaller joints are affected. As time goes on, larger joints can be affected. Anytime I see a younger patient, sometimes female, family history, and there's multiple joints that are painful, I always keep rheumatoid in the back of my mind. Other things to consider: psoriatic arthritis and the differential diagnosis, osteoarthritis, lupus, viral arthritis, Lyme's disease. So many symptoms. It's not just one joint, it's multiple joints. And, you can have the low-grade fever, depression, fatigue, weight loss, dry eyes, dry mouth. And joint pain is oftentimes on both extremities. So common signs of diagnosis of rheumatoid arthritis: morning stiffness, tenderness, decreased range of motion, low-grade fever, arthritis on both sides of the body. We don't always see that, especially in gout. Positive blood test, symptoms that last for at least 6 weeks. And radiographically, the classic finding is periarticular erosions. So the diagnosis: physical exams key, x-rays can be helpful, MRI limited value. The lab tests that we oftentimes order are sed rate, CRP, rheumatoid factor, and anti-CCP antibody. And clinically, in a later case, not early on, but as time goes on, you can see some weakness in the intrinsics, and especially at the MCP joints, I see a lot of changes with rheumatoid, where you get the synovitis. Synovitis can happen in the wrist, and then the classic ulnar drift is seen as the fingers go off in the ulnar direction at the MCP joints of the hand. And here's kind of a radiograph. Radiographic finding with rheumatoid: the joint space is narrowed. You have periarticular osteopenia with the juxtaarticular bony erosions, some subluxation of the joints. MCP joints, they always, start to volar sublux as the cartilage wears down. Sometimes the x-ray doesn't look horrible, but there can be central cartilage wear with joint subluxation and quite a bit of laxity and erosions around the periarticular surface of the joint. As time goes on, rheumatoid nodules can form. So looking for these on the physical exam are always key. There can be an ulnar drift to the hand, as I talked about. Boutonniere deformities, they're common it's where there's hyperextension of the DIP joint and flexion of the interphalangeal joint at the proximal portion, and then swan neck deformities, which is the opposite. There's flexion at the DIP joint and extension at the PIP joint. So those are all changes, and the boutonniere and swan neck deformities, we can break those down into further classifications, but it's hard to use a hand when you start having these deformities. And then some other conditions I see quite often are von Jackson syndrome and Manner-Felt syndrome. And this is von Jackson syndrome. There's some arthritis at the DRUJ, usually a spur. We call it a caput ulna, and that spur leads to some rupture of the capsule, and there's a large spur that causes some bony erosion, and the extensors to the small and ring finger rupture, and then you lose ability to extend the fingers and see that hand loses a normal tenodesis effect, and there's some tenosynovitis at the wrist. Manner-Felt syndromes, where the flexor tendon ruptures to the thumb. So we call it the flexor pollicis longus tendon. It ruptures as it crosses the wrist. There's usually a bony spur off the scaphoid. The tendons, tendons like to go by smooth objects. If there's anything rough that a tendon passes on, such as a bone spur, a screw, hardware, anything like that, it can fray and rupture a tendon. So with this, people are using their hand and all of a sudden they lose that function and they can't bend the thumb. And then you have to start working it up for Manner-Felt syndrome, where you can't flex the thumb at the IP joint and the tendons rupture, and doing a tendon reconstruction or transfer is something to restore function and addressing that bony spur. So rheumatoid arthritis medications are key. Anti-inflammatory steroids, disease-modifying drugs, biologics. Therapy can be helpful with stretching, strengthening, bracing, and surgery. It can be helpful too with synovectomy, cleaning out the inflamed synovium. And then other surgeries are tendon repair, tendon transfer, arthrodesis, or arthroplasty. And here's an example of a rheumatoid hand. You see the right hand underwent surgery. The ulnar drift is corrected. This is what we'd call a rheumatoid hand reconstruction. There's a synovectomy performed at the MCP joints, and then the extensor hood has to be rebalanced. The ulnar intrinsics are released, and the metacarpal phalangeal joints of the index, long, ring, and small finger are usually replaced with some type of implant. A common one is like this one on the right side of the screen. It's called a Swanson silastic implant. So here's another picture showing a rheumatoid hand reconstruction. These implants, they're good. They don't last forever. There can be wear and tear, and the picture on the right shows revision where the implant failed and it had to be revised. So these are good surgeries. They don't always last forever. You'd like them to, but there can be even complications long term after surgeries from wear and tear. Next, osteoarthritis. This is the most common type of arthritis that I see. Wear and tear. I think, we tell patients it's wear and tear type arthritis. There's pain and stiffness are kind of the hallmark symptoms that we see. The basal joint is most commonly affected, and then followed by the DIP and PIP joints. The articular cartilage, the cartilage wears down. There should be a nice cover or the nice form, the gristle or the cartilage that covers the end of the bone, the articular cartilage. So that should be nice and smooth. As we look at it in surgery or put a scope in and look at a joint, it should look smooth, like looking at a ping pong ball. As there's wear and tear, that the joint, with the joint and the cartilage, it wears down and it can fissure, fragment, fray, and eventually it leads to grade 4 chondromalacia, where there's exposed bone, or we call it, it could be bone-on-bone arthritis. So it can lead to pain, deformity, stiffness, difficulty using the joint. Risk factors of osteoarthritis: age, more common in females. Heavy individuals, it affects more the lower extremities. I don't think it makes a big difference on the hands. Injuries can be, be a cause of arthritis, where we see post-traumatic arthritis. There's a definitely a genetic component, and joint problems can lead to arthritis, such as an infection or a septic joint that wasn't treated early, laxity of a joint. Any patient with joint laxity, that joint just can wear in a funny position, and it can wear the cartilage down quicker, or malalignment of a joint. The diagnosis, oftentimes arthritis in the hand you can achieve most of the diagnosis with your physical exam and history, and also it's nice to have an X-ray to look at the bone and see the joint and see the type of changes. MRI, sometimes they're done for other things, and that can assess the articular cartilage a little better, but by no means do you need that to diagnose arthritis. Common clinical findings in the hand. At the distal interphalangeal joint, we see the Heberden nodes or the bony spurs. The bony spurs at the PIP joints are called Bouchard's nodes or nodules. And then at the basal joint, the classic deformity is a palmar adduction deformity, that the thumb is brought over towards the palm, and it's hard to get your hand around objects. So on examining these patients, always doing the basal joint grind test, just putting a little grind on the basal joint. You often can feel some crepitus grinding, an inflamed joint, it can elicit pain. Sometimes patients have crepitus and grinding, there's no pain. So arthritis in the hand, it can be very painful and debilitating, but at times, I see patients where they have a lot of arthritis, but the pain, isn't a main component. And for those patients, we don't have to get too excited about surgical treatment options. Here's a X-ray finding of severe basal joint arthritis. You can see a zeta deformity in the thumb. So that palmar adduction deformity, that palm, the thumb comes over to the palm so close, it's hard to get the hand around objects. So when you try to grab, a cup or a vase, that hand, you just can't use a thumb. You can't use that thumb as a prehensile thumb to wrap around. So what happens is the volar plate and capsule at the MCP joint stretches out, and you get hyperextension of the MCP joint and, that deformity. This patient could benefit from surgery. Treatment, anti-inflammatories can help with the pain. Splints can modify some and decrease some of the joint reactive forces and rest these areas. OT can be helpful to show exercises and teach patients how to perform daily tasks that can be less stressful on the joints, and cortisone injections are oftentimes beneficial. Here's a common brace for the basal joint arthritis. It's a hand-based thumb spica splint that usually the hand therapist makes, and they can help quite a bit. Surgical treatments. There's, many type of surgical treatments. Things to consider: synovectomy, osteotomy, maybe in earlier stages of arthritis. As arthritis is worse, we start thinking of arthroplasty or arthrodesis. Here's a common approach to the basal joint. And then here's some examples of radiographic changes on x-rays. So the first one on the left, the trapezium, or that arthritic segment right at the carpal bone at the base of the thumb, we excise that. So that's usually the first step. After excision, a few other things can be done, and most people would do what we call a ligament reconstruction and tendon interposition, where we take a tendon, reconstruct that ligament, and then make what we call a tendon bundle or anchovy and stuff it in that joint to act as a little padding or cushion. It's probably the gold standard surgery for the typical patient with significant basal joint arthritis that's symptomatic. The other option is an arthrodesis or fusion. The middle picture shows fusion here. There's plate fixation, the basal joints fuse, And, you know, patients do well with this. I always say fusion for a younger patient who's more of a laborer and needs more heavy duty work on the hand, and they have to have that hand to lift, push, and pull, and they have years of doing it. I think the fusion gives them much more durability and pain relief. And then implant arthroplasty, the picture on the right, you probably won't see that done in this country. In Europe, they do it some, but these are plagued with complications of dislocation, periprosthetic fractures, and there's a very high rate of complications. So doing something with where there's low complications and good outcomes would be the preference, and that would be one of either the basal joint arthroplasty with ligament reconstruction or arthrodesis. And here's another example of treatment for the PIP joints. There are some fusions that are done with K-wires, or joint replacement is done as well. And then the DIP joints, most notable option is joint fusion. Replacement is another possibility. Most times we fuse those joints and patients are happy. Another option is you can replace that joint, preserve a little motion and preserve a little more length, and that's another viable option. So in summary, hand arthritis is common. There are several types. Managing the patient's pain and function are very important. So goals: pain control, maintain function, and disease modification. Thank you.
So we have some questions. Do you recommend hand ointments such as Voltaren, as well as hand massages or hand soaks in Epsom salts, etc.?
I think those are fine. Every patient's a little bit different. I do have a lot of patients who they love the Voltaren gel. I have some that love CBD ointment, you know, Blue Emu, or like the Capsaicin cream. Those are all some creams that patients oftentimes talk about, and every patient, it may work different for. The Epsom salt, the warm soaks, I think can be helpful. Everybody's a little bit different though. And I would tell someone to try those things and see what type of relief they get, and hopefully it's helpful.
Dr. Berta would like to know what kind of dog you have in there, its name and sex.
It's a male. He's 4.5 years old, and it's a Vizsla. And I don't know what he's doing something. He's a bird
What's
dog.
his name?
Boomer.
Boomer.
Yeah, sorry.
That's cute. I think you already answered this. Can a cortisone shot help relieve OA pain?
I think the cortisone shots are very beneficial, especially in the hand. The basal joint, they're very common, and there's a lot of patients. I may do an injection. Sometimes it takes pain away for a year or longer. I think that's a good outcome. Everyone's different. Sometimes it may be a few months, sometimes 6 months, but occasionally someone doesn't respond as well. But I think injections are a great start, and it's something that can hopefully cool that hand down. Hopefully, I tell patients, we can hopefully cool the pain down, and hopefully that pain will eventually fizzle out and not be a major component, and you can do everything you want to do. But in the cases that it doesn't or isn't helpful, then we start thinking about surgery.
And what is the recovery time for surgery?
On the base of the thumb or basal joint, arthrodesis or arthroplasty, I tell patients it's a good 3-month recovery. It's not the quickest thing to get through. There can be a little pain, stiffness therapy, and it's a good 3 months. But at that 3-month point, I'd say 95% of patients are very happy that they went through it because of the pain relief.
Dr. Berta says she has one in Winchester is his name of the dogs.
Winchester? Oh, great.
Yeah.
We'll have to get them together. What type?
Awesome. One moment, please. There was a request for Dr. Szerlip's email. Dr. Szerlip's email is bzerlip, S-Z-E-R-L-I-P-S, I'm sorry, L-I-P at orthoneuro.com. And she's a Visla.
Yeah, wow. Nice.
Any other questions for Dr. Cassandra? Thank you, Dr. Cassandra.
Thank you. Have a good night. Thanks for coming. Bye.
Thank you for attending our Q1 CME seminar, Orthopedics for the Primary Care Physician. We will be hosting 3 live seminars at the OUH-COM Dublin campus in Q2, 3, and 4 this year. More information to come. If you have any additional questions about the services OrthoNeuro provides, please contact our practice liaison, Jeff Worth, at 614-402-2204, or email him at jworth, W-U-E-R-T-H, at orthoneuro.com. This concludes our seminar. Thank you and have a great evening.
Well, thank you.
Thank you.